Hello, everyone. My name is Cameron Bumbleberg. I'm a public health master's student in Dr. Kenzig's theoretical health behaviors class. Today, I'll be applying the health behaviors learned over the past several weeks to middle-aged male smokers. Before we get into the actual presentation, I need to go over some definitions. Tobacco use is defined as any type of participation in activities regarding the consumption of tobacco products. This can include cigarettes, e-cigarettes, chewing tobacco, cigars, and vaping products. Tobacco use prevention. Tobacco use prevention is the prevention of any future use of tobacco products. Tobacco cessation. Tobacco cessation is the discontinuing of the use of tobacco products. The overview for the project. The target population for this project is middle-aged males between the ages of 45 and 64 who are current smokers. This is the age range where most chronic conditions begin to occur, and the use of tobacco products worsens the effect of chronic conditions. In the United States, there are roughly 38 million adults who smoke an average of 20 to 25 cigarettes per day. Those who smoke more than 25 a day are considered a heavy smoker, while those who smoke under 20 are considered a light smoker. There has been a link of adults who smoke with an increased rate of cardiovascular diseases. Many theories have been used to understand and develop interventions for smoking behavior, but the social cognitive theory would be most successful in smoking cessation and lower rates of cardiovascular diseases to smoking. The problem with cardiovascular disease. According to the CDC, about 47% of Americans have at least one of key three risk factors for heart disease, which are high blood pressure, high cholesterol, and smoking. Different social and genetic determinants can influence the risk factors, but the population should be cut broad because of differences in literature addressing the relation of smoking to specific behavior theories. The risk factors for cardiovascular disease include smoking, lack of exercise, poor diet, obesity, high blood pressure, high LDL or low HDL cholesterol levels, family history, and or of age. Health risk related to smoking. Tobacco use is associated with increased risk of many diseases and conditions. In addition to tobacco being addictive and creating dependence, research shows that tobacco is correlated with increased risk of many types of cancer, cardiovascular diseases, hypocholesterolemia, which is high cholesterol levels, hypertension, diabetes, respiratory diseases such as COPD, emphysema, chronic bronchitis, and asthma, and then fertility problems in men. It is not just the amount a person smokes, but also the combination of how long the person has smoked and what they are consuming. Some products contain more nicotine compared to others. Smoking can also cause changes at molecular level that leads to some of the potential health issues mentioned earlier. Smoking and cardiovascular diseases. The link. With each puff of tobacco product, you are inhaling an assortment of chemicals that damage every part of your body. The problems that it correlates with cardiovascular diseases is that smoking releases triglycerides into the bloodstream, lowers good cholesterol, causes blood to be more sticky and likely to clot, damages cell lines in the bloodstream, and increases buildup of plaque and or causes a narrowing and thickening of the blood vessels. Those of the lower socioeconomic status are more likely to engage in smoking, either through the direction from tobacco companies and or from peer groups earlier in life. Populations in this community have much higher rates of cardiovascular disease in conjunction with increased rates of smoking and stress. Lower socioeconomic populations are less likely to reach out and receive treatment for chronic conditions or seek medical attention to aid in quitting smoking. Populations who reside in moderate or high socioeconomic status and those who have obtained their bachelor's and above are more likely to seek out medical advice for quitting and more likely to seek out medical attention for chronic conditions. The ecological model is broken up into several categories, but on top of one another. The levels are individual, interpersonal, institutional, and community. Using the ecological model, we will look at the factors that increase the motivation to smoke. These are not all the answers, as a person's motivation can be adapted and warped on all levels of the model in a given amount of time. For community, it's the absence of programs directed at lower socioeconomic areas. Institutional. Is tobacco companies directing ads at lower socioeconomic areas to prevent product use. Interpersonal, social groups with other smokers or parental influence earlier in life. And at the individual level, it's the low self-efficacy. The largest factor that contributes to the rates of cigarette use is low socioeconomic communities being targeted by tobacco companies to increase product consumption. Lower socioeconomic communities are more likely to contain blue-collar workers who smoke because of the type of job they work and allows them smoke breaks. And they most likely came from backgrounds that promoted smoking. Low socioeconomic communities are less likely to seek out anti-tobacco products because of the amount it can cost and actively search out for alternative ways to smoke. Understanding smoking behavior using behavioral theory. The theory of planned behavior, also known as the theory of reasoned action, states that attitudes, subjective norms, and perceived behavioral control together shapes individual behavioral intentions and behaviors. According to Paul, the theory of planned behavior can be applied to the aspects of smoking. Paul and a group of researchers went to suburban metropolitan areas in Sydney to compare the social context between disparities to help develop tobacco control efforts. Across all groups of socioeconomic status, age, and gender, they found common themes as sense of relaxation, enjoyment, and satisfaction. These are expected from smokers as they use smoking as a way to find enjoyment or cope with everyday stress. When looking at the disparities, they found that low socioeconomic older adult men were less accepting of smoking restrictions. They smoked more heavily when accompanied by smokers. If restrictions were tighter, low socioeconomic men would seek alternative methods instead of seeking medical help. Using the theory, this behavior is expected and shapes their subjective norms. It is expected that low socioeconomic men would be less willing to adhere to smoking restrictions and less likely to seek help because of the cost of treatment and loss of their enjoyment. Perceived threats and fear appeals. The protection motivation theory states that the fear appeal argument initiates a cognitive assessment process that considers the severity of the threat event and the probability of occurrence of the event, and the efficacy of recommended behavior response. In basic terms, a person sees a threat, and based on their behavior, it determines how they respond to the threat. The key components of the protection motivation theory are the extended parallel process model and the risk behavior diagnosis scale. Good conducted a study on smoking in Aboriginal communities. They used the extended parallel process model and the risk behavior diagnosis scale to identify a person's self-efficacy and reactance in developing smoking habits. Researchers found that a person's self-efficacy is related with developing habits like smoking because they do not perceive a threat. They also found that a person who perceives a threat is deemed too much by them that the person will begin to show denial, reactance, and message derogations and forego the threat. The trans-theoretical model of change. The trans-theoretical model, according to Ivy, the smokers can be grouped into the first three categories of the stage: pre-contemplation, where the individual is not ready for change; contemplation, where the individual thinks about making a change, but is not in the immediate future; and preparation, where the individual is ready to change and intended to make changes in the immediate future. Ivy found that 38.1% fell within the pre-contemplation, 38.3% in the contemplation, and 23.5% in the preparation stages. Based on the model, it shows that smokers were not looking to change their behavior, or they have thought about changing but not in the immediate future. According to Fajol, 88% of smokers aged 40 and older were in the pre-contemplations and contemplation stages. They found that readiness to quit included younger age, higher BMI, higher educational level, higher pharmacological attempts to quit smoking, and greater negative versus positive attitudes about smoking. This agrees with the previous study that majority of smokers reside in the first two categories. The social cognitive theory. In understanding of smokers' behavior, there is not much research using the social cognitive theory on middle-aged adults, so adolescents were used. Beck has stated that adolescents are at increased risk of smoking if they have characteristics such as short temper, poor coping skills, and if they live in an environment that promotes the behavior as positive. According to Binstrup, a smoking initiation was often situational, unplanned, and sometimes used in negotiating social relationships and identity. Smoking cessation. The use of apps, the theory of planned behavior. The use of apps might be beneficial in aiding smoking cessation because of the accessibility at the palm of our hands. Researchers in the UK developed an app that provides help either through daily therapy or through information only to test the effectiveness. The daily therapy provided new motivation away from smoking and helped to plan a new behavior. Researchers found that there were only 10% smoking cessation rate when using the daily therapy. When looking at low socioeconomic status, they found that low rate can be correlated to the inequalities in online literacy. Perceived threats and fear appeals. Europe implemented pictorial health warning labels in 2012 on the majority of tobacco products to promote awareness of the dangers of tobacco smoking. Health warning labels often take the form of fear appeals, defined as messages designed to motivate behavior change through the fear by showing the negative consequences. Using these pictorial messages, pictorial health warning labels, and text warnings, researchers wanted to see which produced a more adaptive response. Also found that when exposed to pictorial health warning labels, 65.4% of participants had an adaptive response, while 16.5% had a maladaptive response. Textual warning had a less than adaptive response. Pictorial warning labels were effective in changing a person's self-efficacy, eventually leading to smoking cessation over time. Trans-theoretical model change. Aveyard used the trans-theoretical model as a guiding framework for studying the smoker's position on the termination of behavior. Researchers used a stage-based intervention that was adapted for smoking behavior to help navigate a person through the 5 stages and progress to cessation of smoking. The intervention evaluation showed that trans-theoretical model-based stage intervention was no more effective than this non-stage-based control intervention improving smoking cessation. Another study conducted by Schumann used motivation enhancement smoking cessation interventions to help promote smoking cessation. The intervention strategies were used to monitor and observe change in behavior if a change occurred. The study evaluation showed that the trans-theoretical model interventions were not successful as a non-stage interventions when evaluating smoking cessation behavior. Social cognitive theory. Zane conducted one of the first social cognitive experiments on adults outside the clinical setting. The intervention had a 3-week training course of 5 sessions. The training course had 4 of the 5 standardized teaching material based on different components of cigarettes, diseases, and cessation smoking. The training program had elements of social cognitive theory embedded in the program. Researchers found that the intervention group had higher increased proportion of participants quitting smoking. They found that the 6-month continuous absence rate at the 1 year followed up was still high as 22%. The intervention increased emotional and social self-efficacy. This increase in both emotional and social self-efficacy usually correlates with the increase in odds of cessation and continued cessation. Proposed interventions. Interventions should be focused on raising the smoker's awareness of harmful risk factors, changing their attitudes, and increasing their self-efficacy. Researchers should first look at the motivation for why smokers pick up cigarettes. Different age groups have different motivations, and for this project, the interventions need to be looked at what motivates middle-aged males to smoke on a daily basis. The key components. Use the stages of change model to split smokers into each of the 5 categories. Based on where they fall in the model, use the social cognitive theory to design interventions to help promote knowledge about cigarettes, their dangers, and smoking cessation. Steps of the intervention. The first step is to help educate smokers about the potential health risk of smoking and give strategies to limit cigarette consumption. This helps move smokers from pre-contemplation into the contemplation, where they're more open to cessation strategies. The action stage may prove beneficial from specific interventions if carried out with similar social groups. Many of the tested interventions had benefits in the short term, but did not succeed in the long term. It is important to continue to focus on maintaining smoking reduction and cessation during the maintenance stage. Consider the ecological and social cognitive constructs and provide social groups that help reduce the smoking behavior, and consider using the social media as a connection and support device. Some cultural and ethical concerns. Interventions for broad populations create more issues based on socioeconomic status and subcultures. Specific cultures have different uses for the use of tobacco products. For example, the use of smoking is used as a religious purpose for Native American ceremonies. Smoking cessation may not be a priority in low socioeconomic areas because of the lack of accessible healthcare and financial support to aid in smoking cessation. Middle-aged adults must learn about the dangers of smoking. Social group participation is key to helping with smoking cessation and should be positive. Thank you for listening, and here's my references.